Webinar is Guidelines and Review of Tricuspid and Other Imaging Protocols. So before we get started, there's a few housekeeping things I want to go over. This is a live webinar where you'll have the opportunity to ask questions and have them answered by today's speaker. To ask a question, use the Q&A icon at the bottom of your Zoom screen. Ask your questions at any point during the presentation. The questions may be answered at the end depending on how much time we have left. So any unanswered questions will be made available when the recorded webinar is posted on ASC's Learning Hub. And finally, if you have any technical problems during the webinar, submit a message using the Q&A feature, and we'll have a technical support expert here to assist you with any problems you might encounter. And now let me introduce today's speaker. So Dr. Hahn is Professor of Medicine at Columbia University, Irving Medical Center in New York, and Chief Scientific Officer of the EchoCore Lab at the Cardiovascular Research Foundation. So it's my honor and pleasure to welcome Dr. Hahn. You can have the floor.
Great, thanks. Can you see my slides?
Yes, I can see them.
Okay, so I'm going to apologize in advance. We've had some technical difficulties, and I am concerned that the slides will stop working in just a minute. So we'll do our best. And again, I'm trying to keep an eye on the open Q&A. So just please type your questions in there. We'll attempt to answer them as we go through the presentation. These are my disclosures. The learning objectives today are obviously to cover the anatomy of the tricuspid valve, sorry about the typo again, understand the essential imaging views for hemodynamic assessment of the tricuspid valve, but also we'll cover the imaging assessment of other anatomies as well, the interatrial septum and the left atrial appendage. There was a question from the last webinar that I wanted to address a little bit more fully. The question had been, should stroke volume be quantified in every study? And I had said yes. But the clarification to that is that quantitative Doppler assessment of stenosis or regurgitant severity requires a measurement of stroke volume. And because it is one of the key and integral methods that we have for assessing particularly regurgitant severity, that's why I said yes. But I wanted to clarify that because we obviously have 3 different methods that are recommended in our guidelines for quantifying the severity of regurgitation: the proximal ice velocity surface area method, so PISA, the volumetric Doppler method, and that means we have to calculate the stroke volume, so that was your question, and then the 3D color Doppler vena contracta area. And each one of them have strengths and weaknesses, as has been covered by prior guidelines in 2017. Similar to aortic regurgitation, we have the same type of recommendations for the quantitation of mitral regurgitation, but where we differ is in the quantification of tricuspid regurgitation, because at the time of the writing of that document, there was less support for performing and guidance on performing quantitative Doppler. But we'll cover that in this webinar, and hopefully then you'll be able to understand that we do need the stroke volumes, obviously, when we're trying to corroborate the severity of regurgitation. And so using all 3 methods to us is a way of just making sure that the pitfalls of each of the different measurements is overcome by one of the other measurements. And so that's why we do recommend looking at stroke volume on every patient. And in addition, I think it needs practice. So I wanted to stop for a second and just talk about the deep transgastric and the transgastric views. I'd shown this in the last webinar. But when you're doing a deep transgastric to get the aortic valve in aligned, the flow across the valve and LV alpha tract aligned with the insonation beam, you want to do a left flex and an anti-flex. For the RVOT, it's a right flex and an anti-flex. And that's what will give you, the best on-axis view of the RV alpha tract. For the transgastric imaging, remember I said that there were 2 different ways of getting the LV alpha tract, and the other is a shallower, so not a deep transgastric, but a transgastric. So now we're a little bit shallower. We're at the level of just where the LV would be, where you might look at it in the short axis view, but now we've gone ahead and rotated it. This happens to have given us a beautiful view from a 70-degree view, but most of the time we're rotating out to a 3-chamber view, which would be somewhere beyond 90 degrees. And then for the RV outflow tract, it's just a little slight positive rotation, maybe 50 degrees or so, in order for us to get this beautiful RV outflow tract. So those are the main ways that we're going to look at RV outflow tract and LV outflow tract, and how we'll calculate forward stroke volume in the setting of tricuspid regurgitation. So let's talk about the tricuspid valve now. And the anatomy of the tricuspid valve is somewhat complex. It happens to be the largest valve and the most anterior. Therefore, it's the furthest thing from our probe. And in addition, we can't, unlike the mitral valve, which we talked about in the last webinar, we can't actually get all the way over to the dome of the right atrium. That's all the way in the right chest. And therefore, we're never going to be able to line it up, or typically never line it up as if we had this Valentine view for the mitral valve. We just are not going to be able to do it because of the anatomy. The other complexity of the tricuspid valve is that it's obviously an irregular annulus. It's a D-shaped annulus composed of a flat septal region and then the curved anterior and posterior regions. It has multiple crisscrossing muscle attachments from the base of the RV to the base of the attachment of the tricuspid valve. And so you'll remember seeing those, because when you're trying to measure the basal RV dimension, you end up seeing all these weird muscle bands and you don't know where to measure it. You want to go on the outside of that. You want to try and go to the endocardium, the endocardial surface of the RV. And then it's really almost virtual. The fibrous portion of the annulus is really only in the anterior portion near the aorta. And so otherwise, it's just almost a smooth transition from the right atrium to the right ventricle. And therefore, you're not going to see a nice, clean annulus typically. Now, the other thing about the annulus is that it's saddle-shaped, just like the mitral valve. There's a 20% change in area, perimeter, diameters during the cardiac cycle. And it has this beautiful hinge-like motion. This is not like the mitral side at all. Because it's tethered by the septum, you can see that it's mainly hinging on the lateral side. This is what we're going to measure as the TAPSE, tricuspid annular plane systolic excursion, but it is also what is the main driver for RV function early on, or in a normal patient. And so because of this beautiful shortening, longitudinal shortening, you now are able to really almost passively transfer blood from directly from the right atrium into the right ventricle, and thereby increasing the efficiency of blood flow across the right heart. So this is just a beautifully elaborate and really intricate physiology that has to occur in order for us to see the same stroke volume going across the RVOT as we see going across the LVOT. So again, it doesn't have as much muscle. It's obviously it's got to transfer all that blood, the same amount of blood as the LV is transferring out the aorta, but it's doing it against a closed mitral valve. So now all of a sudden, it's depending upon the pulmonary capacitance. And so it's just a complex side. And all of it is tied together with the tricuspid valve, because the tricuspid leaflet in relationship to the RV is, as you see here, rather intimate. So you have two of the leaflets being attached to the main dominant, typically anterior papillae muscle, and that is going to send off a chordal apparatus to both the posterior and the anterior leaflet, and then the septal leaflet, and then you're going to have other secondary papillae muscles as well. So the posterior papillae muscle, a little bit more variable, oftentimes multiple, will send off chordal attachments to the posterior leaflet and then up to the posterior portion of the septal leaflet. And then you've got these multiple small septal papillae muscles or direct chordal attachments to the septum. So now you begin to see the setup here, right? You've got this septal leaflet that's really attached to the septum directly, as well as through the papillae muscles. And so anything that's going to affect either the septum and its position, or is going to dilate out the lateral wall, is going to separate the two leaflets from the septal leaflet. So now you can kind of figure out what's going to happen when we talk about tricuspid regurgitation. The one other thing we know about the tricuspid valve is that it's highly variable. This is a study that we did with 576 patients from 4 different sites, 2 in the US, 2 in Germany. And we had the interventional imagers look at the transgastric views with and without color or the 3D imaging in order to try and decide how many leaflets you've got, because pathologic studies have for decades and decades shown us that we don't always have 3 leaflets, that there can be up to 5 and 6 leaflets on the tricuspid valve. And it turns out from these views, we can actually see that. And about 54% of the time, the tricuspid valve has 3 leaflets. The rest of the time, it's got some other conformation. And bileaflet valves are pretty rare. And the most common is going to be a quadricuspid valve, 4 leaflets with 2 posterior leaflets. And we developed a nomenclature for calling them posterior leaflets, which I'll cover in just a minute. So now we talked already about the anatomy, normal anatomy of the tricuspid valve. And what we know now about tricuspid regurgitation is that we have the primary regurgitation similar to the mitral valve, where you've got primary leaflet issues, and then you've got secondary tricuspid regurg. Well, it turns out secondary forms about 90% of the patients that we end up seeing, and only 10% have primary, and probably even less because we've separated off pacemaker-induced tricuspid regurgitation into its own category. And so when you look at the functional disease, Denise and Morrow used 3-dimensional echo to show that in functional tricuspid regurgitation, the right atrial volume and the tricuspid annular area determined the severity of the tricuspid regurgitation. That's pretty clear, right? Because the bigger the annular area, obviously, the less coverage you have of the area by these fixed leaflets. The leaflets can grow, but obviously when you develop tricuspid regurgitation, you just don't have enough coverage. Now, the difference, though, is in ventricular functional disease, just like we talked about with mitral, you've got dilatation of the RV and therefore displacement of the papillary muscles and tethering of the tricuspid leaflets. And so that's this row right here is the tethering volumes of the tricuspid valve leaflets. And then when you talk about atrial functional disease, these are patients that have the largest annuli, the largest right atria, and therefore could have a lot of tricuspid regurgitation. But because their ventricles are preserved, then they maintain their conical shape and the position of the papillary muscles, and therefore don't have as much leaflet tethering. So those are the different types that we end up seeing over on this side, where you'll see the tethering. The most dramatic is with the primary pulmonary hypertension, so precapillary pulmonary hypertension. But you'll also see it anytime you have dilatation of the RV and any displacement of the papillary muscles, either the anterior, posterior, or the septal. And the atrial function are the ones that have the biggest right atria. They tend to have the biggest, and then the leaflets are closing closer to the annular plane, almost at the annular plane. And the issue becomes that with chronicity of the disease, then you begin to get more and more RV dilatation. And in that setting, you now can have some tethering, even with atrial functional disease. These are examples, obviously, of primary disease. So Epstein's anomaly, endocarditis, flail, tricuspid valve, carcinoid, all of them a primary problem with the leaflets. And we used to place cardiac implantable electronic devices, or CIEDs, into the primary group. But what, so the main morphologic etiologies were initially separated out into primary versus secondary disease. And the problem is that cardiac implantable devices don't always have to affect the leaflet. They can affect the subvalvular apparatus and the papillary muscles, and they can not be actually attached to the leaflets, but just prevent them from closing. And so now all of a sudden, it's not really a primary disease. It's a disease of coaptation secondary to a pacemaker. And so the PCR tricuspid valve working group, which is a European working group that was developed with many of us in the US as well, published this document suggesting that we should actually have 3 categories of tricuspid regurgitation severity based on morphology, and that's going to be primary, secondary, and separate category for CIED related, and then the functionals are divided again into atrial and ventricular functional. So it becomes important, obviously, for treatment modalities. It'll become even more important as we have more and more treatment, different types of treatment modalities, because certain morphologies may obviously be more effectively treated with specific devices. So for instance, atrial functional, this is an annular problem. And so because it's an annular problem, then it would make sense that perhaps an annular device might do very well with these patients as far as efficacy. And then the ventricular functional tricuspid regurgitation is a ventricular problem. So again, you might have a little bit of trouble thinking about an annular device when the leaflets are all the way tethered into the ventricle. But leaflet devices like the TEER devices might be just fine, or transcatheter replacement devices. So learning about the morphology becomes super important, and not only for decision making as far as devices, but obviously for our guidelines. And so our guidelines obviously will separate out patients with primary or secondary disease, and then also look at all these other different things: right ventricular size, right ventricular function, pulmonary hypertension, whether or not it's pre or post capillary. And the main difference, most of the criteria are roughly the same. The main difference is that there are devices now approved in Europe, and therefore transcatheter devices is has a 2B indication for intervention in the tricuspid valve in Europe. Now, one of the things we like to do is look at RV size and function. I'm not going to go over that, except to say that it has been validated. To be able to do a TAPSE off of a transesophageal echo. And so this is the study that validated the anatomic end mode. Obviously, I don't particularly like anatomic end mode, and not all machines are going to give you anatomic end mode. And so what we like to do, and we has been validated using transthoracic, but we believe is basically the same thing as anatomic end mode, is to measure it on 2D. And so we're measuring diastolic and systolic TAPSE and getting an idea. And then the thing we really like to do is look at RV strain. So RV strain from a 4-chamber view allows you to look at pre and post devices. Happens to be compassionate use of an EVOQUE device, a transcatheter replacement device, and showing that with the reduction and elimination of all tricuspid regurgitation, you have an increase in afterload and uncovering of the mechanical dysfunction that was existing in the setting of tricuspid regurgitation. And so the free wall strain goes down from a 23 down to 11, and this is quite standard in our patients with tricuspid regurgitation. So quantitation, and we're going to go through this briefly before we get into the actual imaging, but qualitative, semi-quantitative, and quantitative, just like with mitral regurgitation. The real issue is that we really have to take with a grain of salt color flow Doppler. So remember that the jet area is based on momentum. This patient has absolutely horrific disease, but the right atrial pressures are high, the overall pressures are low because it's a right heart, and therefore you see that the color Doppler jet looks kind of small. This is torrential disease, just you've got to believe me, we measured it in a number of different ways. And the key here is that color Doppler jet area is dependent on momentum. And in the setting of the low pressure tricuspid side, the right heart side, then the color Doppler jet area may actually be only a quarter of the size of the mitral regurgitant jet area for the same regurgitant orifice area. And therefore you want to be super careful using color Doppler jet area as any kind of measure of anything on the tricuspid side. In fact, the European guidelines are very clear that color flow area of the regurgitant jet is not recommended to quantify the severity of TR. Color flow imaging should only be used to diagnose the presence of TR, and a more quantitative approach is required when more than a small central TR jet is observed. This is absolutely, I would agree with all of those statements. And so the other problem that we have is measuring a single diameter of the vena contracta, because this is what tricuspid regurgitation looks like if you have a tri-leaflet valve. You can imagine that when you have bileaflet valve or a quadricuspid valve or 5 leaflets or 6 leaflets, that this regurgitant orifice becomes extraordinarily complex, and there's no way that a single linear dimension of a vena contracta is going to really describe the severity of the regurgitation. So current guidelines recommend the measurement of it in a single, typically apical 4-chamber view. However, in the setting of multiple jets, as well as these irregularly shaped jets, I think that this will need to be changed. And there is some evidence that averaging the orthogonal views may better define severity using a cutoff of 9 millimeters. Now, what about color continuous wave Doppler shape and density? Well, this is one of my least favorite ways of determining severity, because remember, you're using continuous wave Doppler. So that's an ice pick through a regurgitant jet. And if you're perfectly aligned with a mild jet, you could actually get a dense profile or a moderate jet. And so therefore you want to be a little bit careful with density, because if you're improperly aligned, you may think that you don't have severe when you do, or when you're perfectly aligned, then you may think that you have severe when you actually have only moderate or less. The overlap is just tremendous. And so you want to be careful about using density. Now, how about contour? Well, there are no studies out there, the one that I show referenced here, that looked at contour as one of those methods to assess severity. And it turns out it's not a bad method. It's just that the triangulated contour actually detects torrential disease, not just severe. So all of these patients have severe disease. Every single one. These are the patients that I showed you before, and they all quantified as having severe. And yet this is parabolic, very dense, but parabolic. This is also parabolic, kind of late systolic even. And this is the early systolic triangulated shape of the regurgitant jet. This is the one that has torrential disease, and we know this from a study that Philip Lurtz did when he looked at invasive measures of pulmonary hypertension versus echo, and he found that the most discordance occurs in those patients with this triangulated shape, or the more torrential disease. And what he found was that you could measure the PA pressure pretty accurately. These are all patients that had severe. So you could measure it pretty accurately in about 77. So 3/4 of the patients are still going to, in the setting of severe T, are still going to be able to accurately measure pulmonary hypertension. But there was a group of patients, only 23%, so about 1/4 of the patients, so not a small number, but not 100%. So 1/4 of the patients had discordance. And that discordance was clearer. So the predictors of the discordance were advanced valvular disease, advanced ventricular disease, either left or right, and then symptomatology also. So New York Heart Association class, LV ejection fraction, et cetera. And it predicted lower procedural success, as well as increased mortality in patients who went for transcatheter repair. Now, what about systolic reversal? We think that this is a specific sign, but it turns out now that we're doing transcatheter devices, it's not so specific. We now see a lot of patients that have persistence of the systolic flow reversal. They tend to be a slightly different pattern. So when you have tricuspid regurg being the etiology of the reversal of flow, it's going to be an early systolic and pan-systolic reversal of flow. And then when you take away all the tricuspid regurgitation in the setting of, let's say, putting in a transcatheter tricuspid valve replacement device, you may still have some later systolic reversal of flow, and that's related to the compliance of the right atrium. So remember, as you start to contract the RV, you're increasing the pressure against the valve, which is transmitted into the right atrium, but because it's so stiff, it's going to transmit it even further into the hepatic veins. And so it's not as specific as we think. And so we want to be a little bit careful, again, about systolic reversal being the only criteria by which you grade TR severity. I would never do that. Now, the guidelines recommend using PEES on 3D color Doppler. So we're going to go over that. And PEES is a great way of measuring severity. Obviously, it becomes a little bit tricky, as you can imagine, depending on how tethered the leaflets are and how complex the shape of the regurgitant orifice. And there are many studies that have actually shown that PEES is kind of limited. So you can do it from transthoracic or you can do it from transesophageal. And the benefit is that it's easier to measure, but the disadvantage is that it's not been validated for multiple or temporally variable jets, which occurs quite often with tricuspid regurgitation. It's not accurate with non-circular or complex orifice shapes. So obviously, you know, if it's a slit-like orifice, it thinks it's a circle, and it's going to really underestimate the severity. And then lots of correction factors have been suggested, one of those being the leaflet angle. So remember, with tethered leaflets, you're going to have a smaller radius than you would if those leaflets were actually flat. And therefore you're going to underestimate. So again, not validated for multiple jets to be used in multiple jets, underestimates in the setting of a hemispheric or elliptical orifice, not accurate for non-planar orifices, and a angle correction factor has been suggested. In addition, it's also not as accurate in the setting of low flow or the low flow right heart side. So not just low flow low gradient, but I mean really the right heart in itself with lower pressures. And therefore there have also been a correction factor suggested for that. And then I just wanted to show you this example where we measured the Pisa radius every frame in the systolic time interval. And you can really see this bimodal peak of the TR radius. And therefore to think that you could actually accurately measure EROA by PISA, I think, you know, with all these pitfalls, particularly for the tricuspid side, is probably not going to happen. I mean, it's going to be very difficult to be accurate. Now, having said that, there's a lot of utility to PISA because PISA quantification has been shown to be associated with outcomes. So we'll never abandon PISA. So this is one of those studies from Topilsky, another one by Ben Fari, this one by Perry coming out of Topilsky's lab, and then the one most recently published by Denisa Muraro and the University of Chicago group. So Roberto Lang and colleagues. And so all of them have used PISA and shown outcomes. So we will never abandon PISA, and we should use PISA to quantify in all patients. And we think the outcomes are, adverse outcomes begin in the moderate range, just like for mitral regurgitation. So somewhere around 30 to 35 millimeters squared, uncorrected, so not corrected for flow. And those patients then should be sent into a level 1 heart valve center for further evaluation. Now, three-dimensional vena contracta area is in our guidelines. The European guidelines suggest that it's still reserved for research purposes, but I don't think so. There's lots of data now that have used three-dimensional vena contracta area and compared them to PISA. And so you can do a 3D VCA, obviously, on transthoracic as well as transesophageal, obviously a little easier on TEE with higher line density and frame rates. And the advantage is that it's a direct measure of the vena contracta area with no geometric assumptions at all. So it could be any irregular shape that it is, and we're going to measure it exactly. And then it could be used following device placement. That may be the best utility of it. And then the disadvantages obviously are, again, it's temporally variable. So I just showed you temporal variability of PISA. The 3D vena contracta area may also be temporally variable depending on the etiology of the regurgitation. And therefore, we in our lab and in the core lab, we integrate the PISA, like I just showed you for PISA, we integrate it over the systolic time interval. And we'll integrate also 3D VCA, and that's how we get them, to correlate the best, sorry. So the data for 3D VCA, they're numerous. I'm just showing you two studies that have correlated it to PISA, and it correlates quite well, but clearly EROA by PISA underestimates 3D vena contracta area by 40%, depending on the regurgitant orifice shape. So again, if it's circular, they may actually correlate pretty well, but once you start to get elliptical or star-shaped, then the correlation goes down with PISA underestimating the true severity of the disease. So in the PCR tricuspid working group manuscript that was just published, this is a beautiful review by Fabian Pra. We outline obviously all the things that you should do. Of course, you want to take a look at the hepatic vein with the caveat that I mentioned. You want to go ahead and look at the average vena contracta widths. You want to do your PISA. So we'll do PISA on everybody. So always remember to baseline shift. And then we will also quantify by three-dimensional echo. But the one other thing that we're doing and that we have also validated is volumetric Doppler. So similar to the mitral valve, we believe that this will be possible. I'm not going to advocate it for you now. This has not made it into the guidelines yet. But again, by measuring the area of the annulus, either using 2 orthogonal views, or our favorite is 3D planimetry, then you can measure the diastolic stroke volume, and it doesn't care whether there are multiple systolic jets. It doesn't care if there are temporally variable systolic jets. You're measuring the diastolic stroke volume, and then you're subtracting the forward stroke volume. And so there are many issues as well. The assumption of a constant flow across the annulus, it obviously requires numerous measurements, which each one of those are associated with errors. But we showed in our core lab that indeed the 3D VCA cutoff and the Doppler EROA cutoffs are very, very close. And indeed that the PISA EROA will underestimate by about 40%. Very, very briefly, there's an extended grading scheme. I'm not going to talk a lot about it. It didn't make it obviously into our guidelines from 2017, but it's been clearly shown that PISA, which is this one, the vena contracta is the spline curve on the left, and PISA is the spline curve on the right. And PISA reaches a plateau, so that beyond a certain, not PISA, vena contracta. So vena contracta width reaches a plateau. Beyond a certain vena contracta width, you're not going to get additional information as far as mortality, but PISA is continuous. And so that's why we do believe indeed that there are increasing grades of severity, and it did make it into the new EACVI regurgitation guidelines that are currently in press. This was presented at EuroEcho just a couple weeks ago. So now let's get into the guidelines. So apologize for all the preliminary stuff, but it allows us to set up why we are doing all these images. So the new level of imaging is the deep esophageal. We'll start with mid esophageal and deep esophageal. And similar to what I showed you for the right heart, you're going to have to right flex. So remember, the esophagus starts way over on the lateral side. This is a patient that obviously has significant dilatation and severe tricuspid regurgitation. So dilatation of the annulus and the RV, severe tricuspid regurgitation. And now the heart lies even more horizontal than those patients that don't have severe TR. And so by moving the probe to the right, using the right flexion, you get a little bit better. You're never going to be lined up, as I said, because the dome of the right atrium is all the way in the right lung field. So you're not going to get there. But it does allow you to somewhat verticalize, so make into almost a Valentine view the right heart. And so the other thing to remember is that as you start to push in, you're going to get closer to the diaphragm and move away from the left heart. So the right heart sits on the diaphragm, but the left heart does not. So that as you start to move in, or at least the left atrium and mitral valve, so as you start to move in and use your deep esophageal view, which are the panels on the right, then you can really see how now we have no right heart structures, no left heart structures as we're imaging our right heart structures. Okay, so right flex, retroflex, always going to be your friend for the AV valves. Okay, so mid-esophageal views are really good, as I already showed you, for looking at the right heart. So this is where we'll do a lot of our right heart size and function analysis. So you can do, as I said, your TAPSE and your RV strain here. This is where we'll want to look at the tethering of the leaflets. We look at tethering all around, but this has been traditionally the view where you'll get the tethering height and the tethering area. Obviously, with three-dimensional echo, you can get tethering volume. And throw on your biplane image whenever you want, and that you could see the images that you'll get as the inflow-outflow view as your orthogonal view. But the inflow-outflow actually is one of our main views, and therefore we want you to always just rotate forward. So this is just mechanical rotation to 45 to 60, sometimes even 90 degrees, depending again on the particular patient's rotation and size of the RV. And this becomes our working view, similar to the mitral side. So on the mitral side, when we're doing tier devices, etc., we like to stay in that commissural view and then use our orthogonal biplane view. And so same thing can happen for the tricuspid valve. I'm just going to show you a couple of examples of a TEER device where we're now using the commissural view as our home view, remembering that now we have unlimited tilt plane rotation. It doesn't have to be 90 degrees anymore, and that allows us to really align with the jets. And then we also have real-time 3D MPR, which allows us to do the same thing, so align with the devices. The deep esophageal view, this again is, as I stated, because we're closer to the diaphragm, we now eliminate having to look through the left heart. So any patient that has prior left heart surgery with bioprosthetic material in either the aortic or the mitral position causes acoustic shadowing in the far field for us, the tricuspid valve for a TEE. And therefore, we really want to try and eliminate the left heart structures to eliminate that acoustic noise. And so the deep esophageal view accomplishes that. And so now you can see no left heart structures in my way. Obviously on a biplane, it's going to be over to the right side, but not directly in view directly in view of the plane of the imaging. And the deep esophageal view does the same thing. So this is a deep esophageal view. You can see very, very little left heart, and really, really imaging beautifully papillary muscles, chordal attachments, the malcoaptation zone. So these are all really important. And then sweeping across allows you to see the coaptation of the septal leaflet with the anterior leaflet near the aorta and the posterior leaflet out the posterolateral wall. So remember that septal leaflet is in the third plane. I'm going to show you this three-dimensional image one more time here, and just play this for you, where you see that the septal leaflet is in the third dimension, so that when you're scanning across from the aorta to the lateral wall, so anterior to lateral or posterolateral, then you're scanning across the coaptation with the septal leaflet. Okay. So moving on, again, real-time 3D multiplanar reconstruction, very, very helpful, because now you can actually perfectly align with the coaptation zone, count the number of leaflets, look to see exactly where your regurgitant orifice is. And obviously, we're using it heavily for device placement. The transgastric views for the tricuspid valve are also absolutely essential. We have to have the transgastric short axis view. So this is the only plane of imaging where you'll be able to see all the leaflet tips at the same time, and therefore be able to count the number of leaflets. And so in this particular case, it's actually probably a quadricuspid, or has at least a commissural posterior leaflet over here. But you can really see from the short axis view the leaflet tips and the chordal attachments. So super important. And then from that view, you can obviously do, and this is just our gastric view doing 3D, and you can do either without or with color Doppler. And this is just other ways of getting to that short axis. So remember, I showed you the inflow outflow view of the RV is a right and antiflex. And then from there, if you just put the biplane across the leaflet tips, you're going to have the short axis as your orthogonal view. You could do the opposite as well. You can actually go to what looks like a two-chamber view first, and then throw your biplane across there, and now you've got the short axis obviously inverted with the septum on the left side of the screen and the lateral wall on the right-hand side of your orthogonal view. Gastric views, because the papillary muscles and chordae are now perpendicular to the incination beam, we get to see them better. So remember that when you're looking at an image from the apical view and you've got a really thin cord, your lateral gain resolution is not as good, right, as your axial. And so if you've got a thin cord that is now lined up with your incination beam, you're not going to see it as well. You're just not. as you are from a gastric view, where now that thin structure is actually perpendicular, you can use axial resolution in order to see it. And that's why we really have to have transgastric views to see the chordae, and we should not rely upon the mid esophageal views to really allow us to see those really thin chordal attachments. They're just not gonna, axial resolution is just not that good. From the transgastric views, you can also see the papillary muscles, and this is where we designed the nomenclature. So the nomenclature is based on, oh, I'm going to skip a slide, based on identifying the anteroseptal commissure, the anterior papillary muscle, and the interventricular septum. So the anteroseptal commissure is always adjacent to the aortic root. It's a very constant anatomic location for that septal, for that commissure. And therefore, that's why we want to start the counting from the anterior septal commissure. And then when you find the anterior papillary muscle, that separates out the anterior from the posterior valve leaflets. And then when you see the interventricular septum, that's what tells you that's a septal leaflet. So now you have all the structures that you really need in order to name the leaflets as anterior, posterior, and septal. And then if you've got two posteriors, you start numbering them from the most anterior one. So if you have two posterior leaflets, the one next to the anterior leaflet is P1, and the one further posterior is P2. Same for the septal. The one next to the anterior leaflet is S1. The one more posterior is S2. So that's the nomenclature that we are now using in order to speak to each other in the same language. It would be important to identify the number of cusps, because it turns out that outcomes may indeed be determined. There are 2 studies now showing that morphology makes a difference as far as outcomes for the TEER devices. Now, what about the deep transgastric views? So remember I showed you in the beginning of the talk that using the deep transgastric to get on axis for Doppler. Well, the same will occur for the tricuspid valve. So look at how beautifully aligned we are from a deep transgastric. It's like it's an apical view, and therefore we should be aligned with flow. So the insonation beam, ultrasound beam, should be aligned with flow. And that then allows you to take a look at not only beautiful continuous wave and pulsed wave Doppler, but also do your PISA here. So this is proximal ice velocity surface area. And indeed, we even got 3-dimensional, because it was so clear, we got 3-dimensional color Doppler volumes and did a 3D VCA. So we were able to, from our transgastric view, deep transgastric view, accomplish the PISA quantitative Doppler and a 3D VCA all in the same setting. And so this is kind of the images that we will need to do the quantification. Remember, this is all a work in progress. So if you're doing a TEE for TR, you're probably doing it as a pre-procedural for a device, because we have no devices approved in the United States right now, or you're doing it for surgery. And so again, we need to be pretty prescriptive about the images that we obtain in order for us to be able to quantify this disease, since quantification to me is still a work in progress. Remember also the 3-dimensional imaging is key. It's absolutely essential. We can use it from any view. This is mid, esophageal, distal, and transgastric views. So I'm going to move on to the interatrial septum. We'll do this relatively fast, and I apologize for getting to you late. But clearly, we're pretty darn good at imaging the interatrial septum for atrial septal defects. So this is a primum disease that you see with a bridging leaflet. So this ended up being an AV canal, and these 3-dimensional images of the bridging leaflet are courtesy of Greg Ensing from Michigan. And then this is the IVC, sinus venosus IVC type. And so again, you see the absence of the septum near the inferior vena cava, either from a 0-degree view or almost a bicaval view. And then the SVC type. So this was just a contrast study, not because we didn't think there was an AST. We obviously see the AST, but was to try and determine whether or not you had anomalous pulmonary vein flow as well, which we did. So there was negative contrast within the SVC from inflow from a pulmonary vein. When you're looking at the inner atrial septum, 3D is also your friend. This is something that we use frequently to look at all of the rims of the ASD, since although there are now devices that allow us to place devices even with some minimal rims. It's important for us to know those rims, because it will help us decide on device choice. Remember that it is a dynamic structure, and so giving some dimensions in both systole and diastole may be important. The interatrial septum anatomy, when it's intact, is really, really important as well, because obviously to get to the left side with any transcatheter devices, we're going to have to we typically want to go through the interatrial septum. Obviously, we can do transapical devices, but the new standard will probably be all transseptal. And so the anatomy of the transseptal is shown in our document very, very clearly. And so I recommend that you read that. And what's important to understand is that lipomatous hypertrophy of the interatrial septum is not hypertrophy of the interatrial septum. It is lipomatous hypertrophy. So it is extra cardiac fat that is going in between the folds of the right atrial wall and the left atrial wall. And so that infiltration of fat separates out the two walls and makes it look like it's a thick wall. But in fact, although they could be fused to the fat, often they are not. And so when you do a transseptal through the lipomatous hypertrophy, you risk having gone out the right atrium into the fat, and then back into the left atrium through the left atrial wall, and you won't know it until you take the catheter out, because you're tamponading that space when the catheter's in, and when the catheter comes out, you're no longer tamponading the space. And so you'll end up seeing, and we've unfortunately done this before, you'll end up seeing tamponade rather quickly. Okay, so remember that we're really good at seeing the fossa. This is just an en face view of the fossa, and us guiding the transseptal and making sure that we remain in the fossa. I'm not gonna belabor this point because we're running out of time. But my favorite view to find the fossa is indeed the bicaval live 3D, either narrow or full sector. Or you could do, this is a 6-beat multi-slice, but it gives you an idea of the interatrial septum and its relation to the mitral valve as well as the left atrial appendage for whichever device you want to do. And then obviously we also want to be able to make sure that the height of the fossa is going to be adequate for a device to fit into the left atrium. Okay, I'm going to just skip the next one and go on to left atrial anatomy. Now, these are beautiful images from Mohammed Sarek, showing you obviously where the left coronary artery is. There is a great cardiac vein in there as well, and how well you can image the structures of the left atrial appendage, obviously with 2D and 3D imaging. And it's important for us to identify the anatomy, because this may also in the end help us determine the device that we're putting in. So this is a figure that is in your guideline. Now, one of our main jobs is to exclude thrombus. And so you can see from these images that you can go from dense smoke to sludge, which is just super slow flow, really, really slow, to actual thrombus. And sometimes what you have to do is use ultrasound enhancing agents. And so this was one of our cases that came in for left atrial appendage closure. This was done on the table. So frequently we're doing our TEEs for the first time. When they come onto the table, they've already had a pre-procedural CT scan, which apparently didn't pick this up. And, because there's no flow down there, so they just thought the apex ended there. But in fact, there was really, really dense sludge. We were worried about a thrombus. So injected contrast, and you can see from the initial that, oh gosh, it certainly is looking like a thrombus. But as you wait, because it's sludge and slow flow, obviously the contrast eventually fills the space. And this is a patient who had a successful left atrial appendage device placed. New study showing that you may be able to place the device if the thrombus is very, very apical. So I'm not going to go over that, but again, making it important for us to be able to tell them the characteristics of whatever you're seeing in there, the echo density. Is it actual thrombus? Is it just sludge? Sludge, you can go ahead and perform the usual procedure. But if it's a thrombus and you want to put a device in, now they have to be very careful about their pigtail catheter and not allow it to go deep into the apex. The current devices that we're using are going to be the Watchman Flex device, and then the nice, beautiful review that came out of NYU. Obviously, many of the anatomic exclusions are no longer valid in the setting of the Flex device. Now, the new device that's been approved is going to be the Amulet. This, again, is going to take some experience to understand what the anatomic exclusions as well as inclusion criteria should be. Remember that in the end, we may be looking at 3D ice to do some of these atrial procedures. And so this is, again, 3D ice, commercially available 3D ice that we performed during one of our cases for TCT. And we used both because we're still trying to investigate how good the 3D ice is and how confident we feel about whether or not they give us comparable imaging. And I think you can tell that they give us pretty comparable imaging. So it is possible in the end that we will be using 3D ice. And although the interventionalists will control the actual probe, we will be controlling the imaging. And so because these probes will allow us to have all the modalities of three-dimensional imaging that the TEE probe does. So we'll be needed to perhaps direct the manipulation, use the 5 different 2D and 3D modalities of the probe. And certainly for transesophageal imaging, we highly recommend you trying to use the new 5th level, the deep esophageal view in your imaging. Thanks for your attention.
All right, so that's all the time we have for today. So as a reminder, any unanswered questions are going to be made available on a Q&A handout when the recorded webinar is posted on our Learning Hub. And we want to thank everyone for participating today, and also give another very special thanks to Dr. Rebecca Hahn for presenting on behalf of ASC. So once the webinar is over, you're going to be directed to your survey for claiming your CME credits. So please do not exit the browser.